Thank you. Well, it's a pleasure to be at the Pan American and a pleasure to participate in this session. I really have to thank Drs. Lucas and Rizzoli for making my points for me so we can go through this really, I think, pretty quickly. And I would ask Dr. Peitzman a number of questions. If the answer's in, and it's 1-to-1-to-1, why do we need to continue to debate this topic? Maybe because the answer's not really in. I mean, it seems silly to think that every patient needs the same strategy, and a more personalized approach is probably a better idea. The coagulation of trauma is a complicated topic. Is it the plasma or the overall approach that is really translating into safe lives? And none of this really makes sense in a vacuum. Some of the earliest work that suggested that more plasma is a good idea was ours, and this was a retrospective, I remind you, review of blood use at the Shock Trauma Center, looking at about 5,000 units that we gave in 2000. And what we said was, when all was said and done, if you got a unit of blood, you got a unit of plasma. And the same thing was true for platelets. And we began to say, if you're going to give the plasma anyway, why not give it earlier? Earlier plasma made some sense. But is it 1-to-1 or 1-to-2 or 1-to-3? I would submit to you that that's far from decided. This is data from Denver, Gene Moore's group, Jeff Kashik, suggesting that maybe the answer is 1-to-2, not 1-to-1. The curve from that study, again, demonstrating that it seems that adding 1-to-1 doesn't improve results over simply doing it 1-to-2. And Davenport's study saying the same thing, that it looks like it's around 1-to-2 or maybe 1-to-3, where you stop getting the additional plasma doesn't get you increased survival. Now, Dr. Peitzman put this slide up for you to see, and this was the Holcomb study demonstrating that high platelets and high plasma ratio save lives. The part he didn't put up for you was that graph from that same study. So, maybe. That's right. So what you can see here is that these are the ratios, and this is the outcome. So at the same level of plasma ratios, mortality was almost double in one center versus the other center. So is it the plasma ratios that's really making the difference? Or maybe that center shouldn't be a level 1 trauma center any longer if it's really the plasma that makes the difference. That was presented at the American Surgical. This was contrasted with our large single center study where the ratios had no difference on mortality and the use of 1-to-1 had no difference on mortality. And this has been hotly debated. Dr. Moore points out that a large percentage of papers that have come to the Journal of Trauma and have been presented at the AAST recently are on this subject, again suggesting that the answer is not yet in, and it appears to be about a 50-50 split as to whether 1-to-1 actually makes a difference. A table from a recent paper by Gene and his colleagues demonstrating the same thing. I would submit to you the answer's not in. And I would say that the landscape has changed on so many fronts over a small period of time. We now use much more plasma. That seems reasonable. But the best ratio is unclear, and it's hard to dissect out the exact role of the plasma. In the last 20 years, Mike Rotundo first described or coined the term damage control. We've used many more targeted resuscitation strategies that Dr. Ivaturi. We use less crystalloid. We have more attention to hypothermia. We have new ventilator strategies. We use earlier CVVH, and we use more plasma. What is responsible for the increase in survival? I would submit to you that we don't really know. Damage control surgical techniques probably make some difference. Careful attention to crystalloid resuscitation, data from Fred Moore's group, looking at pushing oxygen delivery numbers, gives you a higher incidence of abdominal compartment syndrome, multiple organ failure, and death. Targeting the resuscitation more is important. And this is the graph that Dr. Peitzman showed you from the military. Let me remind you that these are all patients that are very, very similar. They're healthy 20-year-old males, not the typical trauma patient that I see. There's no incidence of substance abuse. Many of them get blood and plasma in the field. They have long field times. They have IED blasts as the principal injury mechanism, which maim, but often have compressible hemorrhage with tourniquets. They get warm whole blood and they get factor 7A. And is it the plasma alone that made the difference? I'm not so sure. Now, we try to study this and we look at scores. This is the ABC score. This is used widely as identifying people that are going to need massive transfusion. These are two recent patients that I cared for. A 17-year-old kid came in with 2 stab wounds to his left shoulder, a blood pressure of 70 with pulsatile bleeding. He's got an ABC score of 2. He's into the study. He's going to get massive transfusion, but we get vascular control quickly. We revascularize him. We do a bunch of things. He gets 6 units of blood and 6 units of plasma because you have to get 1-to-1. Did he really need 6 units of plasma? Probably not. On the other hand, this is a guy that has a crush injury that has a blood pressure of 40 and a positive fast. He's got an ABC score of 2. He has a terrible set of injuries. He gets a liter of crystalloid, 35 units of blood, 35 units of plasma. They have the same ABC score, but they're terribly different patients. I'm not so sure it's going to be so easy to study this. And coagulopathy is a complicated thing. We heard earlier, it's tissue injury, it's shock, it's endothelial cell factors, it's inflammation. And that's the cartoon we used to use, saying it was 3 things: hypothermia, acidosis, equaled coagulopathy, but it's probably a lot more complicated, talking about clotting deficiencies and complement and many other things. This is interesting data on looking at massive transfusion protocols. This was a pre and post massive transfusion protocol paper. You can see that the patients remained the same, that the minutes to first transfusion got faster with the massive transfusion protocol, but the ratios didn't change at all, yet the massive transfusion protocol was associated with increased survival. So better survival, but no difference in plasma red cell ratios, suggesting that the ratios were not what were saving lives. And then just looking at the coagulation profiles, and we can go through this relatively quickly because Dr. Rizzoli very elegantly described to you what TEG is, and looking at the various components of TEG. Again, a figure from one of Dr. Moore's papers demonstrating resolution of some of the coagulation problems on TEG. There's a nice study from Nystrom et al. Recently looking at TEG after trauma and looking at clot strength. Patients were not different, but the odds ratio of survival or not survival was highly correlative with the clot strength when the patient got here. Again, nothing to do with plasma platelets and the fact that the components of the TEG correlate relatively poorly with standard coagulation profiles. And lastly, are there other things other than plasma and platelets that make a difference, and hyperfibrinolysis may be one of those. This is the CRASH-2 study that a lot of patients, significant problems with study design maybe, but still a statistically significant difference when tranexamic acid was given to these bleeding trauma patients, and better results when given earlier. This is another set of data from the United States military, again suggesting that tranexamic acid may be very helpful in patients who are bleeding, particularly when given relatively early. And so I think we're left with an algorithm that's a lot more complicated than just give 1 to 1 to 1. This is from one of Dr. Moore's recent papers, and you can see it has a lot of moving parts in it. It's damage control surgery, it's damage control orthopedics, it's tailored resuscitation using TEG, and it's more plasma, but maybe not 1 to 1 to 1 that gets you to from the top of the algorithm to the bottom. And so I would summarize and say that newer resuscitation strategies using earlier and larger amounts of plasma probably make sense. We're getting ready to start a 1 to 1 versus a 1 to 2 randomized prospective trial. Why? Because we don't have the answer yet. The changes in trauma resuscitation, including earlier plasma, have occurred, but until more data is collected, there's no proof that 1 to 1 is any better than any of the other resuscitation strategies. Thank you for your attention.